I don't know if this is working.
It's not working yet?
Is it working?
Ah, there we go.
Good afternoon, everyone. Thanks for coming for the Grand Round 2020. My topic today is non-vitamin K oral anticoagulation update. So before we're talking about our topic today, I want to show a slide for the coagulation cascade and platelet activation. So when the trauma happened, endothelium's exposure to the tissue factor, to the all the platelet, and a lot of factors, cascade change for the clot making. So when the platelet attached from the von Wellman factors or other acceptors, then they triggered. Is it large enough you can see? Everyone can see? TXA2, ATP, and the thrombin, and present to the surface of the platelet. And all these factors will be increase the platelet attachment. So also the ATP, they have a different type of the ATP receptor with P2Y12 and the P2Y1. And when the ATP presented irritated, and then they also can increase the thrombin presentation on the surface of the platelet and increase the platelet aggregation. So this is the factor 10A to inhibit the effects 10A to inhibit the prothrombin to become thrombin. So one molecular effect 10A can suppress about making 10,000 molecular of thrombin. So it's a very powerful for the effects 10A inhibitors like Xarelto and Eliquis was used in the clinic now. And for the direct thrombin inhibitor we use is Pradaxa is a direct thrombin inhibition. So compare with the factor 10A inhibitor and compare direct thrombin inhibitor. Looks like in the clinic trials, you will see a lot of patients probably has a more myocardial infarction or instant stenosis in the dabigatran group, as the Pradaxa group. It's possible related because the thrombin is overwhelming and overcome the direct inhibitor from the medicines. But with the factor 10A inhibitors, is suppress more thrombin to make, and there might be a more benefit for the ischemic event prevention. So this is the major end of the platelet attached to each other is through the 2B3A receptors. So a lot of different area has targeted medicine is trying to target a different area to block platelet aggregation. So my today's focus is because we have more and more using new oral anticoagulation this year, and we all face a lot of acute coronary disease, and we also face a lot of valve disease. So it's very confusing to compare to warfarin, which is more better and which one is more risk. So this is the topic I'm focused today. In the clinic real world, it's very difficult for making the right decisions because among the patients undergo PCI, 5 to 8% of